Hello and welcome to BoneUP, the podcast all about bones. I'm David Armstrong.
Hi, and I'm Richie Abel, and we're going to bring you the latest in bone research. So whether you are a patient living with a bone disease, a family member, or a healthcare professional, you've come to the right place.
If you want to learn more about your infrastructure of calcified collagen, this is BoneUP. Hello and welcome to a very special episode of BoneUP. It's one of our live episodes which we're recording here at the European Calcified Tissue Society Congress in sunny Girona in the Catalonia region of northern Spain. Nice to see you again, Richie.
You too, David. It's always nice to catch up in person. And welcome, listeners. We're glad you were able to join us. We're going to try and give you a flavour of the conference this year. There's lots of really interesting talks. There's a great lineup, some fantastic speakers, and hopefully you'll learn something new.
There's some stuff on basic bone disease. There's interesting science. I'm looking forward to some of the sessions on osteogenesis imperfecta.
AI seems to be a really big theme this year, and predicting disease severity.
Lots of interesting things to hear, and hopefully we'll be able to persuade some of the speakers to come to the microphone and to tell you all about it. So, listeners, we're delighted to have our next guest, Louise Thomas. Louise is a professor of metabolic imaging at the University of Westminster, originally from Wales, like Richie, so they have a connection there. You don't usually come to bone conferences, is that right? Or tell us why you're here and what you give a fantastic presentation. So tell us why you're here and what you were talking about.
Oh, thank you, David. So yeah, this is my first time at this conference. So I normally attend either radiology or obesity conferences. And I was invited to speak at the symposium by the Bone Marrow Adipose Tissue Society because one of the many things we measure by MRI is vertebral bone marrow fat content.
And so, yes, so when we think of doing MRI, we always think about bones, but you see lots of other things as well. You see muscle, you see fat, and everyone's interested now in the fat content inside the bone as opposed to outside the bone. So tell us a little more just about that and why we're so interested in it.
So it's really interesting. It's like when people think about fat, they think about themselves and what they look like. People have a very visual idea of how they see themselves. But what they don't realize is, our bodies are so clever. We store fat pretty much everywhere. We can store fat in all of our lean organs. Think about your liver, your pancreas, your muscles. But we also store lots of fat inside our bone marrow. And that it increases as we get older. And it also increases with things like type 2 diabetes and obesity.
And that can help predict other things because you're obviously an imaging expert. So by performing this imaging, seeing the amount of fat in different parts of the body, that can predict some outcomes, can it?
Yes, we can look at fat stored in different places and we can predict your likelihood of getting the early onset of disease, things like type 2 diabetes, cardiovascular disease, fatty liver disease, and even link into things like osteoporosis and reduced bone mineral density, which are also related to fat stored in bone marrow.
How do you measure the fat content of the skeleton and the body?
Well, when I first started many years ago, we would have to do all of this manually. So it's a really time-consuming process. We would MRI scan people. They would lie in the magnet in like Superman position, and we would take slices all through the body. And then we would spend days literally colouring in all the different depots we were interested in. So it might take me about a day to work out how much visceral fat, that's the fat on the inside, and the subcutaneous fat on the outside somebody had. But now we do lots of work where we use deep learning, which is it's like a form of AI really, where we manually do a few images and then we train a model how to recognize it, and we can automatically measure, say, the volume of your liver, or in this case, the amount of fat inside your bone marrow.
And you've been working with data from the UK Biobank to get the MRI scans. Could you tell us a little bit about the bank and how you use it?
The UK Biobank is the most extraordinary thing. It's really transformed MRI as a field. So when they originally designed the UK Biobank, it was only going to be lifestyle, genetics, and it was to understand the development of middle-age disease. And then in 2012, they had the crazy idea of MRI scan in 100,000 people. Now, this was revolutionary. Nobody's ever done an MRI study that big. So we do MRI scanning of the brain, of the heart, and the body. So it's not the full body, it's neck to knee, because we acquire the whole thing in 9 minutes. But because we had so much data, it actually changed the field and how we analyze it. So now most people working in this use deep learning.
What do you think the next steps of the research are? Yesterday you showed the most beautiful images where you had sectioned out some of the muscles and organs in the body, and you'd also sectioned out the fat content in the body. And the images were just absolutely mind-blowing. What are you going to do with these images next now you've got them?
Well, what we've been doing is basically trying to analyze everything. I mean, we started off, because my main interest is fat, just looking at the visceral fat and the subcutaneous fat. And then we added all the major organs, if you think about your kidneys, your spleen, your liver. And then we've moved on to muscle. So not just total muscle, all the individual muscles. We can look at 21 different muscles in each thigh. And then, so you can start looking at the individual contribution of things towards disease. So it might be that there's one particular muscle that's really important. I mean, we found the gluteus maximus muscle, like how big it is and how much fat you store in it, is a really important health predictor. So then you can advise people to do particular types of exercise to improve health outcomes.
So the potential, and I could be wrong about this, but the potential eventually is that if you had an MRI, let's say for some other reason, let's say an MRI of your prostate or ovaries or something, that a model could run in the background and say, oh, we've noticed you've a lot of fat in the gluteus maximus muscle, or a lot of fat in the bone marrow, and that could flag up potentially other conditions or other poor outcomes.
That's exactly right. So a lot of the scripts we've developed could be applied to routinely acquired clinical data in the NHS, and as well as the radiologist reporting what might be wrong with you or what might be healthy. They could get this added value by looking at fat, muscle, which can be used to predict what diseases you're likely to develop and outcomes. So it's a really powerful thing that we could be making more use of.
And I suppose now you've got the deep learning methods working, and you can automatically segment and, I guess, measure the muscles and organs in the body. Potentially, this is something that clinicians could have. I guess if this is feasible, the MRI scan would come off a patient, all the data could be processed and then delivered to the doctor for the consultation.
Exactly. And a lot of this could be taken from CT, not everything, but it is kind of modality open. So, you don't have to have a particular type of MRI, a particular type of scan for lots of this. I mean, the possibilities really are quite vast.
So what are the next steps then? What are the challenges that we might have to overcome in order to deliver these techniques into clinic for the benefit of patients?
I think bringing new technology into the NHS is always very complicated because it's not one organisation where you say use a bit of code. They all operate quite separately. So it's kind of getting through that is very difficult. And it's also, when we first developed, we used to measure liver fat by spectroscopy many years ago. And we kind of worked on people in the department, volunteers, and we found lots of people with very high levels of liver fat, and we would contact GPs and say, look, we've noticed this in this healthy volunteer. And because it was like a novel research finding, we used to get quite rude letters back. It's like, what do you want us to do with this measurement? That makes no sense. So you would really have to make sure people understood what you were giving them as additional information and why it's useful to them.
Thank you very much for joining us today. That was a really interesting chat, and thank you for your wonderful talk yesterday.
Yeah, talk was fantastic, and it's been really good to speak to you today. Thank you.
Oh, thank you for having me.
We're delighted to introduce our next guest, Professor Bram van der Eerden, welcome.
Thank you. Happy to be here.
Thanks for taking the time.
I went to your session today. It was a really interesting talk you gave, providing an overview of new technologies which are going to be able to speed up bone research and perhaps the delivery of new drugs in the future. Could you give us a bit of a brief overview of what you talked about today?
Yeah, thanks for the interest in the talk, and I think it's a really important and interesting field that we are entering. So we are dealing a lot with standardized conventional cultures, and we need to move towards a more 3D system. So 3D cultures are the future. And apart from those 3D cultures, we also have new technologies where you can implement biomechanics, by fluid flow, for example, or by mechanical loading. And those models are being used, but not so many as we would like to see. And because of the 3D structure of these systems, we can recapitulate what is happening in vivo in the human situation. And that's, I think, the added value of the new technologies.
So these new technologies are really fantastic then. Basically, you're trying to mimic real bone in the lab so you can do testing on it. And today there were two types which really stood out for me. You talked about organoids and chips. Could you just tell us about those two different technologies and what they're for?
Yeah, so that's a good point. Those two techniques are indeed the ones that are mostly used at the moment. The organoids are kind of 3D cell cultures, and they have the capacity to assemble, and they can also renew. So they're usually involved with stem cells, and the stem cells have the capacity to proliferate and differentiate. So that's a really powerful model. But they are 3D models, they are 3D cultures, but they don't undergo any biomechanical influence because they are sitting in a dish or they're sitting in a tube. And that's why organ on chips come in, because there's a fluid flow involved. So that you can have cells there, you can have multiple cell types that can communicate with each other. But the added value is there that you have fluid flow, you can create shear stress, you can stretch cells, and that's not possible with the organoids.
So you're not just having like individual little bricks, but you're putting the bricks together to make them into shapes that look like bones, if you'd want to say like that, so you can see how they behave as if they were in bones.
Yeah, that would be the ultimate goal, of course, to have this, and have the ship moving also.
And have it moving as well. Yeah.
No, I think that the bricks are the key point here, because one brick could be the cells, one brick could be the loading, another brick could be the culture medium that it has to go through. So the combination, I think, is really bringing the news in the field. So that's ongoing, and I think that's what we're heading for, because it is all human based. So the translation to in vivo and to a human situation will be better eventually when these models are up and running.
So what kind of experiments are people using organs on chips for?
It started all with blood vessel studies, because shear stress is also in our bloodstream. So in that way, that's the easiest, most natural starting point. But blood vessels go through all the different organs and all the different tissues. So eventually people started realizing that we can also use it for liver studies. All the organs that you can think of are somehow involved by nowadays in organ on chips.
It's great the way that in medicine we can copy methods from one branch of medicine and then apply them to a new branch of medicine. I guess maybe one of the most exciting things for the listeners today is the potential for these technologies to be used in drug development and drug testing. Where do you think the future might lie?
The future might lie in upscaling the systems that we have now. We have there are plenty of models out there, but they're quite small scale and medium scale and not large scale yet. And once we have large scale models, and there is movements in that direction, then really hundreds of drugs can be tested at the same time in a single model. Mm-hmm. And then you can really make an effort, and try to predict. For example, if you use patient-derived cells to see, okay, this patient is responding to these and these drugs and not to others. That's going to be the future.
I think potentially that sounds very exciting, certainly to a clinician, in that if I have someone with an infection, I can send a sample of the tissue to the lab. They will test all the antibiotics and come back and say, this is the one that will work.
Yes.
The idea that you could take a tiny sample of bone or cartilage or something and send it to the lab, and they would come back and say, this is the drug for the length of time combined with a certain type of exercise that will be best for this patient. That sounds mind expanding.
Yeah, no, that's the ultimate goal, and I think it's especially useful if there's diseases where you don't have acute issues, because it will take time in the lab also to confirm things, validate things. But especially with bone is not the most dynamic. It's a dynamic tissue, but it's taking time before bone is formed or resorbed. So there is also time in the lab to mimic processes and see which drugs are best or most effective.
Yeah. And ultimately using far fewer mice then, that's part of the benefits of this?
Yeah, yeah, definitely. There is so much pressure on using animals nowadays, and it's costly, and it's you have to breed mice. It takes ages before you have your model, and in this case you can really do quicker analyses. And again, it's human material, so if you see anything of a response, then you can almost directly translate it to the situation in the patient. And that's the added value. A mouse is still, quite distant from a human in many respects. Yeah.
So what do you think the sort of key barriers and challenges are there that need to be overcome in order to realise this kind of vision?
Yeah, so a lot of people have tried these models and they're using it, but they're all one of a kind. So you see lots of models out there, but they're all, tested once or twice. And what we need to do is to have cross-platforms to validate the models that we see. So if lab A does something, we need to check in lab B whether you get the same result. If that's not the case, then the model is apparently not appropriate. So we need to test across platforms to validate, to make sure that what we see in these models is actually translational.
Yeah, that would be wonderful. We do some cell culture in my lab, and we buy known types of cells that other people have used. We're able to work and copy other people's research and develop it. When it comes to these chips, it would be really wonderful if there was just a few brands of chip that we knew about and everybody could use. It would make the data, I guess, more reliable, more repeatable.
Yeah, definitely. It needs to be modular in a way. That if you want to look at pressure, then you could add on a little module that does the same thing in the same chip, but with a module pressing on it, or something that stretches in the same model, so that you can all plug it into the same backbone, let's say, of a machine and a pump, that you don't have to change everything every time for every little model that you have.
If we were using this for real patients in a clinic, do you always see the samples being sent to some big central lab somewhere? Or is it possible that this could actually be reproduced so that many smaller hospitals would all have something that they could use this for their patients?
Oh, that's a challenging question. I'm not a clinician by training, so I don't really know how to answer that. But I think nowadays, if you have materials, they indeed go to a central lab in a hospital. You would have to have these systems up and running, but they have to be operated by people. So I think you still need technicians in every surrounding where you have these samples to run the experiments. Whether small hospitals can do this, I'm not sure whether the infrastructure of smaller hospitals is allowed.
I'm just wondering, is this something would only be happening in special tertiary referral centres with very rare disease, or it's something could actually be translated so that the wider population would get benefit from this sort of
eventually
model?
I think that's definitely the case, but I think you need the specialized hospitals with also the technology and the know-how to test the models. Once you find the drugs that are really promising, you can probably expand to smaller hospitals and use it for patients. Yeah.
The whole session today was really good. It felt like the technology has really come of age now. It's very exciting to see what's going to happen in the next 5 or 10 years. And listeners, these conferences, we quite often hear about experiments that have been done on animals, usually mice. Makes me wonder now how much longer that will go on for. And as we move ahead, we're going to see more and more talks about using real human tissue.
Yeah, that's true. You see it in all kinds of organizations, regulatory bodies that are really shifting their attention to new approach models, and basically stimulate researchers to think about other things than animals for their research. And
it would be great if the research was actually better then. It's not just we're told you can't use mice any longer, so we have to get some workaround. It would be good if we weren't using mice and actually the other models were even better than using mice models, because it's almost where you're going here, which is excellent.
Yeah, in certain ways that is already, of course, what we try to achieve, because if you use human cells, you already make a step towards the clinic. But I think still at this moment, if we can validate things in animals and in these models, then I think we really have a powerful step forward.
Exciting times. Thank you very much for joining us.
Thank you.
Thanks, very
Thanks for having
interesting.
me.
Thank you.
Listeners, we're delighted to introduce our next guest, Dr. Victoria Chatzimavridou. Nice to meet you.
Lovely to meet you both,
Thanks
Richard
for
and David.
taking the time to come and speak to us. I'm so delighted we met you because you're here to solve a problem that I have in the clinic. And I'm getting lots of referrals in the last few years with people who've had radiotherapy to the pelvis, often men with prostate cancer, women with ovarian cancer, other types of cancer as well. And I'm sent patients who I'm told they have insufficiency fractures in the pelvis. And there seems to be very little research or guidance out here as to exactly what I, as a bone specialist, should be doing. So you're here to solve that problem for us. Tell us about what you've been presenting here and about the sort of work you're doing for your PhD, if you would.
Thank you. Thanks very much for the opportunity to talk about that very clinically pertinent problem, as you said. So I'm an endocrinologist by trade. I'm doing my specialty training at the moment in Manchester. And as part of my training, I've been placed at the Christie Hospital. So this is an oncology hospital for the people that don't really know. We do get many referrals of such patients that have had radiotherapy to their pelvis for gynecological, anorectal, and prostate cancers that develop these fractures. These tend to occur between 10 months and up to like 36 months after the radiotherapy. And they often occur at a time where patients have completed their treatment and they develop that pain. And of course, in that population, what they end up developing is a lot of anxiety.
People worry that the cancer has come back, or
Yes,
it's spread to
exactly.
the bone, yeah.
So our trouble is that we don't really know, as you said, what treatment we can offer to these patients. There's very little evidence. And what we do know is that at the time that they have developed this fracture, it's unlikely that bisphosphonate therapy will help them. So what we're trying to focus, the study I'm presenting here is a feasibility study that was conducted by Dr. Claire Hyam at the Christie Hospital. Basically, we were trying to understand if, first of all, if a study involving these patients that are having pelvic radiotherapy would be feasible to try and use a sort of musculoskeletal health package that includes risk stratification and also an intervention to see if that has an impact in the development of fractures. So all the primary outcomes that I'm presenting in the study are really feasibility metrics to try and understand if a multi-center study would be feasible. So we've had very reassuring results that will power this multi-center UK study, hopefully. This is under development currently. And in terms of the other signals that we got, so first of all, we've noticed that patients that in what we call is the moderate risk, so patients that had osteopenia but low fracture risk, and patients that were in the high risk, so patients that had osteoporosis or high fracs, were the patients in our study that developed the fracture, so not the patients with normal bone density. So that was one important factor for risk stratification for planning the future study. Of course, we're only talking about small numbers, so we only recruited 41 patients and we had 4 fractures in total. Yeah, it's quite interesting because it does come a bit in contrast with what we've encountered so far, as in we've had patients with very much a normal bone density in clinic that have developed these fractures. So I think there's still quite a lot we need to understand.
It's different from postmenopausal osteoporosis, essentially.
Yes. In terms of the intervention that we've used is basically depending on the stratification of the patients. They've had something ranging between written advice about bone health for those that were low risk to calcium and vitamin D replacement for those that were moderate risk and oral alendronate for those that were high risk. And those were only 3 patients in the intervention arm, as you would imagine.
Yeah. And is that preventative before you get the radiotherapy, or is that once you've turned up with your insufficiency fracture?
So that's preventative. So it's
preventative.
So the feasibility study was basically we enrolled patients at the time that they were going to start the radiotherapy. So they've had a baseline DEXA scan before the initiation of radiotherapy and all that risk stratification, and then they were randomized either to the intervention, the musculoskeletal health package arm, or the observation arm, and those that were in the MHP arm, they had this intervention plus access to prehabilitation exercise regime.
It's exciting.
Does the bisphosphonate have any other benefits other than preventing fractures? Would it prevent cancers from spreading?
Well, we don't know from this study because we've only enrolled patients that had gynecological and anorectal cancers. Specifically from the gynecological cancers, there were patients that had curative intent or adjuvant neoadjuvant, so not a very advanced malignancy. We know that in prostate cancer we use bisphosphonates for the actual malignancy, and it is beneficial there. But it's something that I think will be more relevant in the multicenter where we are going to have male patients as well. But yeah, you would expect that there's going to be in solid cancers, you would expect some benefit.
This is the potential to change. We were speaking to someone last year saying, if you see a patient, you can help that patient, but if you change a guideline, then you can help hundreds of thousands, millions of patients. So this is the potential of actually improving care for cancer patients for millions of people, if you get a clear answer here as to what's the best approach.
And I guess it's very relevant because the use of pelvic radiotherapy is increasing. We have more and more patients that are surviving and are living with these consequences, and we know that it has quite significant impact on their quality of life. So having a way to perhaps risk stratify these patients and prevent these fractures would be, great.
Yeah, really exciting. Great. Well, maybe you'll come back in the future and tell us about your conclusions then.
Yeah, we'll see, hopefully. Yes, as I said, the multicenter study is currently under development, and then my project, so my PhD is more on the preclinical side of things. The problem we have with clinical studies is that we can't really biopsy the very friable post-radiotherapy bone to try and understand a bit better about the mechanisms that are involved in the development of this fracture. So we have developed a preclinical mouse model whereby we are irradiating the pelvis, specifically of the mouse. Then we're studying ex vivo the changes that are happening in the bone in a microstructural level, but also cellular changes with histomorphometry, bone turnover markers, and nanoindentation for the mechanical properties. So hopefully we'll have more information about the mechanisms as well in the future. But yeah, it's exciting.
It's a really interesting area to be in.
Thank you for sharing your work with us.
Thanks very much.
Thank you very much. Excellent.
Our next guest, we're very happy to have with us Professor Jelena Jadzic. Welcome.
Thank you so much for inviting me.
And you won the prize. Congratulations.
Thanks.
It was the Translational Award for Science.
Yes, it was about our recent research on alcoholic liver disease and its connection to bone tissue.
Fantastic.
Tremendous. I mean, this is a European-wide award, so huge congratulations.
Thank you so much.
Would you be able to tell our listeners a little bit about the research that you discussed today?
Yes, surely. So basically, my main point would be that alcoholic liver disease is associated with bone loss. Maybe your listeners do not know that, but actually the incidence of osteoporosis and bone fragility is quite high. Mostly it's lumbar fracture, which means that they will not feel anything. But actually also the femoral fractures or hip fractures are quite prevalent, which is quite important for their quality of life and stuff like that. And the basic and the most disturbing thing would be that it is overlooked. The clinicians are commonly looking at hepatic complications, but not on others, and certainly not on bone complications in alcoholics.
And how did you do your research then? Were these living patients? Were these dead patients? What did you actually do?
Yeah, so basically there are two parts of our research. The first was on clinic. So basically what we did a retrospective study of individuals with alcoholic liver cirrhosis, with alcoholics without liver disease, and control group. And we just did pure clinical measurements, osteodensitometry of the hip, of the spine, trabecular bones, core, hip structural index analysis, and so forth. And basically not much was seen. So you would say there is nothing going on with the bones. But actually that's not the case if they are still fracturing.
Yeah.
So the other part was on the samples. And basically bone is a really how to say that, magic tissue. It has a lot of features that are not seen on clinics. So you could use a majority of methods to try to analyze the tissue, and that's the reason why you need a bone sample. You could grab it from a patient, but it's quite invasive procedure, so that's the reason why we do it in post-mortem samples. And basically what we did, we analyzed the microarchitecture, but that means, using micro-CT of course, but that means, it means that we analyzed how trabeculae are oriented, how much there is, how thick they are, the cortex, how it looks like, and so forth. And long story short, it is really declined in alcoholic liver disease individuals. And most importantly, with end stage, meaning alcoholic liver cirrhosis, that's the most prominent alteration.
What do you think the next step in the research will be?
So basically, so far, the only group that was doing this was our group in Belgrade and Hamburg, but actually there is not much about it still. So we actually do not know how alcohol as an independent factor affects bone. We don't know how the amount of alcohol affects bone. Is it related to type of alcohol that someone is consuming? Maybe some types could be beneficial because they have non-alcoholic fraction. For example, like a red wine or a beer, they have phytophenols and stuff like that that could be protective. And we do not know anything about it. And the thing that is also striking is that you couldn't really distinguish the effects of alcohol and the effects of liver disease because they are commonly connected in alcoholic liver disease individuals. So if you have a patient with just drinking problem, he will have some form of liver disease. And the only thing you can really pinpoint the effect of alcohol is on in vitro studies.
And to what extent could you tell was the effect on bone mediated via the liver? Because we know there's many other ways in which alcohol could affect the bone directly, nutrition, and so forth. How much was the liver involved in the poor bone?
Yeah, the problem with alcohol is that we have two types of patients. So basically those with end-stage liver disease, I would say a lot, like at least 50%. In individuals who have earlier stages, there are really mild effects.
Thank you for joining us today. It was a really fantastic talk. Congratulations on the Translational Award.
Yeah, thank you for having me and thank you for inviting me. And I hope your listeners learned something today.
Absolutely, and you explained things very, very carefully and clearly. We appreciated that. Thank you.
Listeners, we hope you've enjoyed the first episode brought to you from Girona ECTS 2026. Stay tuned for the next one, which will be out soon.